So if someone comes to you and says, I have an arthritic knee, the standard of care is what?
Yeah, exactly. And this is what got me, I mean, this is exactly why I got into it, is because these patients would come to me as a sports doctor and then interventional pain kind of trained. We're treating chronic pain, which is half of it is osteoarthritis, if not more than half. And so people come in with a knee issue and they've tried physio, they've tried acupuncture, they've tried the conservative management, maybe bracing, and now they're going to a doctor because they're trying to see what's next because I've tried all the conservative routes. And the doctor, generally speaking, will do something called cortisone injections. That's kind of the first line, and still, I think most guidelines still recommend that as a first line. And unfortunately, cortisone is great temporarily as a pain relief because it reduces inflammation. But then what is it doing to the joint? And we know there's enough data, not just in vitro data, suggesting that there's chondrotoxicity, which means cortisone is actually toxic to the cartilage, meaning it eats away at it. And that's in vitro, meaning test tube studies. But then there's in vivo data and actual clinical trial data showing that even one injection can accelerate the progression of osteoarthritis. And this is something that is never done in terms of proper consent, meaning the physician never informs the patient to say that, hey, we're going to do this cortisone, but it may make things worse in the long term. I've never had a single patient who's been told by an orthopedic surgeon that this is a possibility.